Welcome to this medicine masterclass on motor neuron disease. Motor neuron disease is a cluster of degenerative diseases characterized by selective loss of neurons in the motor cortex, the cranial nerve nuclei, and the anterior horn cells. As the name suggests, this is affecting the motor nerves. Upper and lower motor neuron signs can be present, and therefore it's important to rule out cord compression prior to diagnosing motor neuron disease, and any patient presenting with both upper and lower motor neuron signs will require neuroimaging of the brain and spine. Remember, the key differences between upper motor neuron lesions and lower motor neuron lesions is that upper motor neuron signs occur from lesions proximal to the anterior horn of the spinal cord, and lower motor neuron signs manifest from lesions from the anterior horn of the spinal cord all the way through to the motor end plate and the muscles. On inspection of upper motor neuron signs, you'd expect disuse atrophy, increased tone, a pyramidal pattern of weakness, a potential pronator drift, hyperreflexia and clonus, loss of the superficial reflexes, and an upgoing plantar. Whereas in lower motor neuron conditions, you'd expect marked muscle wasting with fasciculations, hypotonia, decreased tone, a focal pattern of weakness with only the muscles directly innervated by the damaged neurons being affected, hyporeflexia, the superficial reflexes will be preserved, and you'd expect a normal flexor response of the hallux. Now, in motor neuron disease, there are four principal types: primary lateral sclerosis, amyotrophic lateral sclerosis, which is the archetypal type, accounting for 50% of motor neuron disease, progressive muscular atrophy, and progressive bulbar palsy. Amyotrophic lateral sclerosis, which accounts for most cases, is a mixture of upper motor neuron signs and lower motor neuron signs, and this occurs due to the degeneration of neurons in the motor cortex as well as the anterior horn cells, and this can also lead to tongue and speech impairment. Primary lateral sclerosis results in upper motor neuron signs and emotional ability. In primary lateral sclerosis, there is a loss of the BET cells in the motor cortex and the cranial nerves. So patients present with hypertonia, spasticity, pseudobulbar palsy, as well as slow tongue movements and increased jaw jerks and pharyngeal and palatal reflexes. They will also have emotional ability with weeping and unprovoked sorrowing or giggling. In progressive muscular atrophy, this is where you have lower motor neuron signs due to degeneration of the motor neurons in the anterior horn cells. And as a result, you'll have all the classic lower motor neuron signs. In progressive bulbar palsy, you have an involvement of the cranial nerves as well as lower motor neuron signs. So patients will present with tongue wasting, fasciculation, and impaired swallow, a jaw jerk, palatal response which is depressed, and absent or quiet nasal speech. To manage patients with motor neuron disease requires a patient-centered, holistic, multidisciplinary team approach, and symptoms are managed. Drooling can be managed with amitriptyline or propanthyline. Dysphagia can be managed by blended food or nasogastric tube with input from the dietitian. Joint pains will require management using the analgesic ladder, and if the patient develops muscle failure, respiratory muscle failure, they may require non-invasive ventilation. Fasciculations can be managed with magnesium and vitamin E. Medically, there are few drug options available. It includes riluzole, which is an anti-glutaminergic drug which can prolong life by about 3 months. And beta-lactam antibiotics can also facilitate through the enhanced astroglycan transport of glutamate. Thank you very much for attending this medicine masterclass.